everybody. Thank you so much for joining us today for another Menopause Talk presented by Let's Talk Menopause in partnership with Revel and sponsored by Alloy. We are thrilled that you have joined us today, and we are excited to be presenting you Dr. Nanette Santoro and the host Nina Coslov. And before I turn it over to them, I just wanted to briefly remind you that Let's Talk Menopause is a national nonprofit devoted to changing the conversation around menopause so women get the information they need and the healthcare they deserve. The chat will not be open today, but we're opening the question and answers. So please share your questions and answers with us, and we will try to answer as many of them as we can. There's going to be a brief poll at the end before we sign off, and we hope everyone will fill it out so we can continue to be responsive to your request and your needs. Before I introduce Nina, the team at Let's Talk Menopause just wanted to make 2 points. Obviously, hormone therapy is a very complex topic and still highly debated topic. We know that many more women could benefit from hormones than are probably taking them now, and with that alleviate their suffering. At the same time, the percentage of women who could benefit, what the benefits and risks look like, those things are still widely debated. And Let's Talk Menopause believes our role as a national nonprofit is not just to bring you the research where there is agreement or just present one side of the topic, but to really give you access to whatever views are out there, whatever debates are out there, so you all can make informed decisions with your healthcare practitioners. So I am excited to introduce Nina Coslov, who is going to be our host. Nina is the founder of a nonprofit called Women Living Better, which is designed to provide education and research to women who are in the transition to menopause. And she's really filling a vital role because the period in the late reproductive stage and the transition to menopause is very understudied and not at all understood. And she is helping to inform women about what they can expect. She just did an important study on women and the symptoms they experience in this transition, which was published in Menopause. She also got the 2021 Media Award from the North American Menopause Society. So thank you, Nina, for hosting, and I am going to turn it over to you now.
Great. Thanks so much, Jessica. First, I want to thank Let's Talk Menopause for organizing this webinar on what I will echo is one of the most difficult to understand topics related to the menopause transition. I'm thrilled to host this panel as it offers the chance for those listening to benefit from the considerable wisdom of Dr. Nanette Santoro. Dr. Santoro is the E. Stewart Taylor Chair of Obstetrics and Gynecology at the University of Colorado School of Medicine. She has been a lead investigator in many important studies about the path to menopause, and her research has been continuously funded by the NIH since 1988. No small feat and a lot of work. Dr. Santoro has been a board member or elected officer for many medical societies, the American Board of Obstetrics and Gynecology, ABOG, the American Gynecological and Obstetric Society, ACOG, and the North American Menopause Society, NAMS, to name just a few. In 2018, Dr. Santoro was elected to the National Academy of Medicine. Dr. Santoro does research. Her name is on 665 papers since 1985 and 343 in the last 10 years. And just as important, she sees many perimenopausal and menopausal patients. There are a wide range of expert opinions about hormone therapy, and Dr. Santoro offers what I see as measured evidence-based perspectives. She is willing to concede what isn't known, where the evidence is contradictory and or lacking. Today's Menopause Talk will take us inside Dr. Santoro's exam room and give us a window into the healthcare choices she makes with her perimenopausal and menopausal patients. To do this, we'll use a case study format. So let's get to it. Okay, case study number 1. Are you ready?
I'm ready.
All right. The patient's final menstrual period was 14 months ago. She's very symptomatic. She has hot flashes at work. Her sleep is poor, both generally and often because of night sweats. These are interfering with her life. She's exhausted, having a hard time getting through the day at work, and irritable with her husband and teenage kids when she gets home. What do you recommend?
So for hot flashes, there's very little doubt that the most effective, fastest way to relief, and this is clearly somebody who's had it up to here, is likely to be hormone therapy. So barring any reasons not to use hormones, my first recommendation for this patient would be to use hormone therapy and see how well it works for her. It's likely to work very well, 80-85% reduction in hot flashes within days to weeks.
Gotcha. And what if she says to you, oh, I've heard that there was this study and I've heard that hormones could increase my risk for breast cancer and stroke. How do you help her think about the risks versus those, considerable benefits you just mentioned?
If there's no medical reason or medical risk that's short term for this person, like a blood clot or something like that, or a real reason not to take hormones, I usually encourage patients to try them because I know that it's the most effective thing we currently have. Emphasis on currently, because there may be other things coming that will be as effective. But right now, this is the best thing we got. It's going to make your symptoms go away. And once you can tell me what the benefits are for you, then we can balance it against what the risks might be, because many of the risks are really risks that accumulate over time. So the longer that the woman's going to take it, the more she may be accruing risks of the hormones. And if it's not working for her, then there's no end of story. So we don't have to have a conversation about risks, but you can't have a seesaw without some weight on both sides. So if all we talk about are risks before she's perceived any benefit at all, we kind of have a one-sided, lopsided conversation.
And do you ever get the question, can you give me something that's natural? I want the hormones that are natural.
I get that question all the time. Despite a lot of advertising that there's some hormones are more natural than others, and that prescription hormones are somehow evil derivatives of natural hormones, it's quite possible there's multiple preparations of naturally occurring estradiol in the molecularly identical form to what the ovary makes. And it's also possible in several different ways to give someone progesterone, again, in the molecularly identical form to what the ovary would make. These are FDA approved prescription drugs. They are therefore, well tested for safety and efficacy in thousands, if not tens of thousands of women. So those are by far the preferred thing to start with. And many women will, feel better just being on what's a naturally occurring hormone.
So you mentioned before contraindication. So let's stick with case study 1, but sort of make it 1A, if you will. How does that change when there's breast cancer in the picture? Let's say it's a first-degree relative, a mother or a sister that has breast cancer.
So that's really a risk of breast cancer. The person herself doesn't have breast cancer. If the patient has breast cancer or a precancerous lesion, we really can't use estrogen. So it's not on the table at that point. However, at least body-wide estrogen, I think we're going to get to other forms later. But if a relative has it, there is some increase in risk to that person. Taking hormones on top of that increased risk causes the same sort of proportional increase in breast cancer risk. It's not like it causes the breast cancer risk to blow up out of control and, oh my God, you're certain to get it now. It's all really a matter of doing the numbers. And what I usually like to do in that setting with my patient is to go through a breast cancer risk model with her. The one that I prefer, everyone's heard of the Gale model. That's very well known. Gale tends to be a little bit optimistic to me. I don't think it estimates as accurately. So I like the one that's called Tyrer-Cuzick, which is what our breast specialists use at the University of Colorado. So I will just call that up. We can call that up online, go through a woman's risk factors, because there's many things that people don't know that they should know. For example, if a woman were to take hormone therapy for 10 years, she will approximately double whatever her background risk of breast cancer was. So if it's 2%, that goes up to 4%. If it's 1%, it goes to 2%. If it's 5%, it goes to 10%. So, whatever it is, regardless of what she's bringing, relative, no relative. So if a woman gains 20 pounds in adulthood, she's done the exact same thing to her breast cancer risk. She's doubled it. And people don't always recognize that, these risks are all around them. If you drink alcohol, you increase your breast cancer risk. So there's a lot of lifestyle or other things that will modify risks of that magnitude. So a woman may not realize that she is otherwise at a very low breast cancer risk. She's had a very early first birth. She's had only one relative. So in that setting, she may choose to go on hormones, and we'll continue to watch, monitor, and be very careful about our breast surveillance. If a woman is at much higher risk than we think, she's had a prior breast biopsy, she's got multiple relatives, then we may try other things first before we even consider hormones, or she may never want to go on them.
Gotcha. And what about, does it matter the type of breast cancer those relatives have had, whether it's triple negative or hormone positive? Does that change your thinking on whether?
It doesn't really. In the Women's Health Initiative trial, they tried to parse out the different types of breast cancer, and there were some differences, but breast cancer is breast cancer. No one wants to get it, and it's not a nice disease to get. And we know from studies like the Women's Health Initiative that it is not a better breast cancer because you were on hormones. The mortality and morbidity of the cancers were the same.
Okay. And what about we're going to get to a situation later with vaginal estrogen, but in this situation, if I added on that the woman was also experiencing vaginal dryness, how does that figure in with you and in your thinking with breast cancer?
Well, if she's having hot flashes and we decide to go with hormones, then she would take body-wide hormones, which would alleviate her hot flashes and probably also treat the vaginal symptoms. So it actually, in some ways, it simplifies it because now she's got two reasons to consider hormone therapy.
Gotcha. And you mentioned, if it's just really contraindicated, what would you recommend on the lifestyle front for this woman if you and she decide together that, she's not willing to take the risk, or you think it's not a prudent risk? What are the kind of lifestyle things in order of what you've seen modify symptoms that you would talk through with this very symptomatic menopausal woman?
Yeah, she is pretty symptomatic, and it sounds like she's kind of at the end of her rope. And I do see patients like this. So depending on where they are in that spectrum of fed upness, will go intermediate, but many of the behavioral techniques are not well demonstrated to help with hot flashes. Things we all think may help, like exercise, does not help at all. It does not impact hot flashes. It just gets used to sweating. There is some cognitive behavioral therapy that seems to be helpful for sleep, and that sometimes can help back off the hot flashes, but there isn't a lot that you can do to control your own hot flashes using sort of mind-body techniques. Many women will, figure out on their own that, camisole, scarves, layered clothing for when you're hot, you're cold, you don't know what's going to happen next. So most of my patients usually have come in and they've already tried those things. A couple of patients of mine have felt some relief from using a cooling mattress. These things are not cheap. There's, you can spray, there's a little spray you can use. Some people carry spray bottles or fans. There's some older studies that look like paced breathing, and some mind-body techniques helped, but newer studies don't look like it helps. Omega-3s don't help. That's been tested in a rigorous clinical trial. And then there are some over-the-counter herbal remedies that have pretty mixed results. If they are low cost and low harm, I will tell patients you may want to try them, but there's not good evidence to recommend them. So usually we'll wind up talking about another prescription medication.
And what is the next level after the hormones, or what is your next line of?
So the only other thing that's FDA approved is a low dose of paroxetine mesylate. And that just is marginally better than placebo in the studies where it got approval, but it's one of the few companies that went to the lengths to get it approved. So that's one that we can talk about, but there's multiple ones that are off-label. They're not FDA approved for that use because the company never bothered, but they are in fact well tested. And the big categories of drugs are really the SSRI, SNRI drugs, venlafaxine, citalopram, escitalopram, and then we can go down the line. Many patients don't love taking them, or if they've been on them, it's helped them. I see a question popping up that abstinence from alcohol can help. And yes, some of my patients will say that that is helpful for them. So quite often, if you're hot flashing, or you may want to medicate yourself with a drink because you feel like you're not sleeping well, that may backfire because it can make you sweat. And some women also will say caffeine and spicy foods and those things, and they may help.
Okay.
They're usually not going to make the miserable ones that wake you up sweating in the middle of the night go away, unfortunately.
Yeah.
The other class of medication that I find is very helpful can be gabapentin. That was initially invented as an anti-seizure medication and now has been repurposed for pain. This was discovered because women with breast cancer who could not take estrogen were taking it for other things like post-op pain, and they would go to their doctors and say, my hot flashes got better, I don't know what you did. And then it got tested. But gabapentin is mostly helpful at nighttime for the nighttime flashes because it can make you sedated during the day. And some women just feel very groggy on it. It doesn't work for everyone. So a lot of this is done by trial and error. There's some blood pressure medications, clonidine, that can be used. There's a overactive bladder medication that has shown some effectiveness. And what I look for in these studies is I look for clinical trials that have been repeated. There's a million studies of something that looks great in 30 women that are menopausal. And it can really cause women to, go into rabbit holes on the internet, chasing their tails, looking at this stuff or that stuff or the other thing. It's really multiple clinical trials that show consistent findings that we really start to believe this actually works.
Great. So let's move on. Our next two case studies will be about a person who has not yet had their final menstrual period. So in other words, they're in perimenopause. An important thing to note here, what is happening in our bodies during perimenopause is different than during menopause after the final menstrual period. And it was actually Dr. Santoro who first gathered the data to show this. Perimenopause is a time of chaotic and fluctuating estrogen and declining progesterone. So estrogen doesn't decline until after the final menstrual period, and this is an important distinction. So case study 3, this patient has had no period in only 6 months. She expects to be menopausal soon. She's not symptomatic, but she has a strong family history of Alzheimer's. And her mother has osteoporosis. She's wondering, can I either start estrogen now or once I've reached menopause? Because I've heard estrogen can help both of these things. What do you think?
Yeah, and that's a straight up, prevention type of scenario that sometimes patients will come in and they want to be proactive. The evidence for hormone therapy preventing Alzheimer's is not good. When you look at clinical trials and you took groups of women that you randomly assigned, this group got estrogen, this group did not get estrogen, you actually see detrimental effects. You don't see improvement, you see a slight increase and this is mostly in cognitive testing. But there is some evidence that older women that take it have a higher risk of dementia from being on hormones, and that's from the randomized trials. There's a series of observational studies when you look at women, and this is different. You're looking at populations of women who have been taking estrogen for many years and comparing them to women who do not. And that is not as valid or scientifically helpful as looking at the randomized trial data. So in this case, the randomized trial does not agree with the observational studies. The observational studies show protection against dementia in those women who take hormones compared to those who don't, who are out free ranging. I tend to believe the randomized trial, so I do not encourage patients to think this is a preventive for Alzheimer's. Much better preventives for Alzheimer's are cardiovascular fitness, paying attention to prediabetes, treating that aggressively, weight control. There's been a remarkable decline in the population incidence of dementia because of increased cardiovascular fitness in our population as a whole. So those are the things that I would have people concentrate on rather than looking at hormones to be the answer here, because first of all, it doesn't look like they're the answer. The best medical evidence we have says that it's not. And there's other things that you can do.
What about on the osteoporosis side front?
And the osteoporosis front, usually, unless the osteoporosis is really, truly terrible and we have evidence that this patient is at high risk, I'm not a big fan of using hormones for someone who has zero symptoms. If you have symptoms, it's great. The hormones are doing double duty for you. They're doing the same. They're going to protect you while you take them. But the truth is we have better bone drugs out now. So this is a patient I would watch closely. And at the sign that her bone density is beginning to deteriorate, I'd probably favor a non-hormonal treatment for that. And this is a field that I think is rapidly evolving. So it's a good thing to, as a consumer and as a patient, to pressure your doctor for their knowledge on it, because we may be changing how we do this. The current guidelines say that you should check bone density at age 65. And I know for me and my family, that just wouldn't work. We would all have pretty significant osteoporosis by then. And until 2 months ago, no one in my family had gotten a hip fracture. And 2 months ago, my mother got a hip fracture. So now finally, I would have been in a category where I would have been looked at more carefully at a younger age. That doesn't really work for me, doesn't work for a lot of my patients. So there is some movement to moving the bone density screening back a little bit. And this is something that I think that women ought to consider even just paying out of pocket for if your insurance won't cover it. Because usually there's a place where you can get a bone density for $100 to $150 as a determination, just to kind of see where you stand. If you have a restrictive insurance company that doesn't want to pay it, that may be money well spent, especially if that's in your family history. But the point of hormones here, why I don't love them, is they protect you until the minute you stop them. And then you basically go through that menopause related drop in bone density all over again. So it doesn't really do anything to change it. It just kind of delays it.
So has it given you a chance to either accrue more, or do you end up back at the same place? So if I were my own randomized controlled trial and I took them and took estrogen for a while and then went off versus not taking it, would I end up at the same place?
At age, like say you took it for 10 years from 50 to 60, exactly. It may delay you a little bit because that slower curve of bone density after that 5 to 7 year loss that we have around menopause might be delayed a little, but probably not a lot.
It would catch up. It would catch up. And what about, while we're on the prevention topic, what about for cardiac health? Estrogen for cardiac health?
Yeah, and the cardiac situation is actually quite similar. And it's very vexing scientifically because we just don't understand it. But again, the randomized trials do not really show cardiovascular benefit. If they do, you have to really parse the data down to women who are in their early 50s or 50 to 60. So in that age group, it seems to favor some cardioprotection for women who take it in that age group. The protection is not dramatic, it's not incredible, and it seems to be short-lived. So for some reason, estrogen seems to be beneficial for women when they're younger. Then at a certain age, it seems to turn on them and actually makes cardiovascular outcomes worse. And in the Women's Health Initiative, that was seen in the older age groups, that cardiovascular outcomes were in fact worse. So for any, the 50 to 60-year-old, which is really what we're talking about the early menopausal women who have symptoms. Again, if you've got the symptoms and you take it, you're probably going to get a benefit with 5 years of use. After that, you're probably not. So it shouldn't be a decision maker, because once again, with heart disease, there's a million other ways that you can prevent heart disease. And it's the same stuff. It's weight control, look at your lipids. We have statins now that we know work for women. They prevent heart attacks. And the data is a little more murky for hormones.
Gotcha. And we talked about specifically, I guess I asked the question about Alzheimer's, but what about just kind of general cognitive decline? Again, same for estrogen and general cognitive decline?
Yeah, we've actually seen, there's that belief that there's this theory that if you take it early,
Mhm.
it's going to give you some protection. So there have been a couple of randomized trials that have looked at this specifically. Pauline Mackey, a University of Chicago neuroscientist, has done a randomized trial in perimenopausal women and has not seen any changes in cognitive markers. We do see that if you take hormones in the perimenopause, some of the things that are specifically associated with perimenopause, word recall, women will perform worse on those tests. And that's in fact one of the things that will bring a patient into my office, because she's noticing I can't remember stuff that I used to be able to remember. It's driving me nuts. I'm afraid I'm getting cognitive, problems. Am I getting Alzheimer's? And the answer almost always is no. Especially if it's verbal recall, a name can't come to you. That's really normal. And there's evidence that once menopause is over and that turbulence of the hormones in the perimenopause goes away, that women get closer to baseline. They don't get back to that same baseline because cognitive decline is just something that happens with aging, but it gets better.
Yeah, I'll just echo, that was the number one reported symptom in our survey. Over 60% of women in the late reproductive stage and the menopause transition, that forgetfulness. And I think it's so front of mind and concerning. Okay, let's move on to case study 4. Again, this is perimenopausal. This patient is still getting a monthly period. She wakes at night around 2 a.m. and she's awake for at least an hour or more for about the 10 days or week or so before her period. She has night sweats for the couple of nights around her period. She feels like she's experiencing new anxiety, less able to cope with things. She comes and tells you, I just don't feel like myself. This is not me. What do you recommend?
In someone like this, and women that have sort of cyclic symptoms, and another great example are migrainers, because they will very often notice that their migraines are now getting worse as they get perimenopausal. And that's typically right around the time of preceding the menstrual period. This woman is already making hormones. She's getting periods, so she's not hormone deficient. And giving her back a little bit of hormone is unlikely to cause a problem. So a little bit of estrogen to cover her with those 10 days, which I will usually give in the form of natural estradiol, a skin patch, just to give her a soft landing, may make these symptoms better. One of the other strategies that can be helpful, especially in a woman who's still getting periods because she may need contraception, is to go back to birth control pills. Women who've used them very successfully earlier in life may do well with them in this period of life. But the important thing about giving birth control pills to a woman in her late 40s with perimenopausal symptoms is to not stop them. Don't have that pill-free week where you go off the pills, take hormones all the time, because that week you go off the pills, all those symptoms are coming back. The hot flashes will come back, the sweats will come back, and it kind of puts a woman back on a roller coaster. Okay. So continuous pills, clamping hormones as much as possible and reducing those fluctuations seems to help with these types of symptoms. There's another strategy that can be used, especially for women with either heavy bleeding or women that need contraception, is to also use a progestin IUD and then just give back estrogen, because it doesn't matter.
Gotcha.
And the question that's bubbled up in the box, which is a good one, is do you need to take additional progesterone? And it's a little complicated. Usually the answer is yes, but if you are still getting a regular period and you're taking a very low dose of estrogen, you may not need progesterone. So sometimes having a reproductive endocrinologist to help navigate some of those decisions can be helpful.
So I understand how the pill sort of just takes over the hormonal fluctuations, but how does the little bump of estrogen with a patch not just add to those? I'm thinking of I wish we could show it, your famous chart of the crazy fluctuating estrogen. My thought is like, oh, you don't want that to go any higher. How does the patch kind of manage that?
Well, there's 2 ways to give it. So typically what I will do is and my best example is migrainers, because we demonstrated in the SWAN study that looking at hormones every day, women that reported headaches had a sharper drop in estrogen before their menstrual periods. So that's the time to give the patch. So if I'm going to give you a patch, I'm going to give it to you that week before your period. You don't really need to take it any other time. And all it's going to do is increase the amount of estrogen by about 10 to 15%. So it isn't creating a big hump in the roller coaster. When women start to get more irregular as they get in that late perimenopause and their periods become so irregular they can't figure out when to take the patch, they can take it all the time. But then, as one of the questions came up, if the periods become too infrequent, then you have to add progesterone, and by then you're kind of on hormone therapy.
Right. I didn't realize actually that you could take a patch on and off just certain days. So that's new learning to me. So are there any tests that you would do for this patient to help her understand how far she was from her final menstrual period, how long she might have to endure this chaos?
We usually, for women that are getting periods on their own, I generally don't recommend testing unless we think there's something else odd going on. Could there be a problem with another hormone, with the thyroid, with prolactin, or the growth hormone issues? So sometimes we'll do more of a hormone workup. For women that have an IUD or that have had an ablation and they're not bleeding and we can't tell, the anti-Müllerian hormone can be very helpful in helping a woman predict. It's probably better at predicting that menopause is not coming than that it's coming, because when it's high, it's going to say, oh, you've got another 3 to 5 years of this at least. But when it's low, if a woman's over 48, it can help predict menopause to within 1 to 2 years. That's about as well as we can do looking at menstrual intervals. So if a woman is 47 and she's gone 6 months without a period, she's 95% likely to be through her transition within the next 2 to 4 years. And it's done.
So
if we need to get more precise than that, we can try AMH, but it doesn't always work. And quite often it's not much better. So these detailed hormone panels, a lot of them are really, I just feel like they're not particularly useful. I think they're useful for the business that's getting the money from them. Women want the information, but your hormones are moving around so quickly on you. The goalposts are changing every day. So to look at your hormones now and try to tell what was happening to you a week ago when you were symptomatic is like looking at your car in the garage and trying to figure out how fast it was going on the highway. It's not helping.
Yeah.
So often they can actually be even confusing.
And so I get lots of, as a perimenopausal woman, I'm always on the lookout and reading what's out there for women. And there are a lot of, as you say, businesses or otherwise, or practitioners that suggest there's a way to measure and balance hormones. And you're basically saying not true.
Yeah, no. And the word balance kind of sets me off a little bit as an endocrinologist. It triggers me, but it's because they're not balanced, and hormones are never balanced for a woman. They're always moving around until menopause, or at puberty and menopause, they're stable.
I mean, I think it's it feels so unbalanced and chaotic that it is an appealing word, but I think it's really important to emphasize that there's no there with balancing during this time and measuring. Okay, let's move on. I've got a time frame here. I want to make sure we get to case 5, and then we have time for questions and answers. So case 5, let's now go back to a postmenopausal patient. The last period was 18 months ago, and she comes to you and says that she's experiencing low libido and sex has become painful. What are her treatment options?
So for painful sex, most often, not always, but most often, that's due to just a syndrome we call genital urinary syndrome of menopause. GSM is the fancy name for it. But the vaginal tissues and also the urinary tract tissues are very, very sensitive to estrogen. The good news here is they're sensitive to tiny, tiny amounts of estrogen. So as estrogen levels get low, women may notice that the vagina is much drier. They don't get lubrication because the lubrication actually comes from the vaginal wall, which exudes some fluid. And that can make sex very painful and aversive. So if it hurts, most people, unless you're a masochist, are not looking forward to having sex. So you're not, that could be the whole problem addressed in one shot. And the best treatment, again, is estrogen, but that's local estrogen applied just vaginally. And there's a number of ways that it can be given. It can be given in the form of tablets that are used twice a week, inserts, vaginal inserts that contain low doses. There's a ring That's a silastic ring that fits kind of like a cervical cap or a menstrual cup or a diaphragm. And that stays in for 3 months. And that slow releases estrogen. And those 3 methods are really the ones that seem to cause the lowest amount of a bump in the bloodstream in estrogen levels. I mean, the bump is tiny and temporary when you first put in the ring for a couple of days. And it's so small that it doesn't seem to affect the estrogen economy in the body, to the point where this is even used in women with breast cancer that are on anti-estrogen drugs when they have this symptom, because there's nothing else that works that well. So, and I think the question that's bubbling up, I don't have the whole question, but it looks like pain during sex with breast cancer. And yes, I will collaborate. I don't usually do this on my own. I will make sure that I've communicated with the breast oncologist for my patient and that she or he is in agreement with that strategy. But sex is a pretty important part of most people's lives. And to give that up because you just have this unbearable vaginal dryness is ridiculous and inhumane. And the amount of estrogen that you're exposing that woman to is so tiny, it does not seem to affect what happens with the course of her breast cancer. So most of the oncologists that I work with at the University of Colorado will be happy to go along with this. The estrogens that are slightly more problematic are the creams. And unfortunately, a lot of insurance companies like to pay for the creams and not the other things. They can cause a little more of an estrogen excursion, especially when women don't use them consistently. Because when the vagina is thin and the walls are very thin, and there's not enough estrogen around, absorption is higher. Once you build that back, it takes about a couple of weeks for women to build that back up. The walls of the vagina get thicker, they get plumper, the cells get thicker, and they make more secretions. Then that's like a barrier. So there's less absorption. So if a woman with breast cancer is using this, I usually tell them to use it very consistently, because otherwise they're going to maybe expose themselves to more risk.
So once you sort of build that back up and things are kind of, the wall is thicker and plumper, is this something that you need to stay on as long as you want to be having sex, or can you build it up and go off, or is this a permanent treatment?
Yeah, it's a permanent treatment. And it's been looked at now in about 100,000 women in the Women's Health Initiative. There was an observational study of women that used vaginal estrogen compared to those who didn't. And there was no difference in outcomes. If anything, there was a slight advantage in the vaginal estrogen users. And again, this was observational. It was not randomized. We're not likely to get a randomized trial, but it was at any rate reassuring.
Gotcha. All right, that's case number 5, and I think we're just about we're in time here for questions and answers. Let's see here, what's in the panel. So let's see, wondering about timing. I've been menopausal for close to 4 years. My symptoms are hot flashes, irritability, low mood, low libido. Been with me pretty much from the get-go. I'm close to 56 and keep wondering if I should try it for a while.
Yeah, I mean, you'd be a little bit of a late starter with hormones, but you have a number of symptoms. You know, what's being described are a number of symptoms that really are attributable to menopause and lack of hormones. So it's reasonable. What I usually do is I have my patients try it for 3 months. The risk to you of trying hormone therapy for 3 months is essentially 0 if you have no contraindications. And at the end of those 3 months, you'll be able to make the call. You know, do I feel so much better on this that I want to stay on it? And then we can talk about mitigating the risks. You know, what are the risks to you? How long should you stay on it? And what's reasonable to do?
Yeah, so the next one is similar. Now this is, I think you may have already answered this. I'm 61, 10 years have passed since my last period. I have hot flashes, disrupted sleep, vaginal atrophy, mild depression, and I get occasional migraines. Would I be a candidate for hormone therapy?
By the time a woman is in her 60s, if they're already on hormones, I will usually try to start getting them off if possible. And some women will never, ever have their hot flashes go away. They stay as bad as they were from the worst part of their menopause. And that constitutes a fair proportion of my practice, who are the people who I call it, you'll have to rip the hormones out of their cold dead hands because they're not giving them up. and nothing else works for them. But this is a time, I would say, to try. I would usually work my way through all of the non-hormonal options with someone like you and see if they work. And if we can achieve adequate symptom control with 1 or 2 medications, it's probably better not to start hormones at this point in life. Any heart benefit, you're probably not going to get. It's just going to be risk, breast cancer risk, blood clotting risk. All of those things go up also with age. So by the time a woman's in her 60s, it's a different story than it was when she was 50. So those risks become a little more prominent, not because hormones cause more of a risk, it's the same proportional increase, but the background, again, the goalposts have moved on you.
Mm-hmm. And another one that's sort of, again, trying to figure out this window of opportunity, I think, is it accurate that 5 years after menopause, hormone therapy is not advised?
Usually 5 years after, I'm not enthusiastic about doing it. Sometimes there's a reason to try it. But usually, and it depends on how old a woman was when she went through menopause. If it was at 45, I might be more likely to try it than if her menopause was at 55.
And how long will you keep a patient on hormone therapy before trying to take her off? So let's say you get her right in the beginning, right after her final menstrual period.
I usually advise patients to try a periodic wean. When the timing is right, there's not a lot of stress in her life, it's wintertime, try slowly tapering off and see how it goes. That gives me an idea, is this going to be, are we in this for the long term? Is this somebody who's going to be a very long-term hot flasher? Or are her symptoms overall getting better over time? And then it's a very easy thing to just go back on. If it doesn't work, it's like, I tried for 3 months, it's terrible. We're not weaning this year.
Yeah.
And every couple of years, usually we'll try. And after age 60 to 65, I really do try to have my patients go off of hormones.
What about some of the new drugs coming down the pike? It says here that increase estrogen receptors, but I think I think this must mean that the new class of drugs that are hitting the thermoneutral zone.
Yeah, there's a new class of drugs, and we do hope to see one that will be FDA approved, at least hopefully by the end of the year, if not sooner. And these look very promising. There's a couple of other things in development that target anti-inflammatory pathways. So there's a receptor in the brain called the Neurochinen Receptor, and that was finally figured out by a female pathologist. Because she saw these neurons go up in the brains of animals that she was looking at that had their ovaries out. And they're called candy neurons in the brain, and they contain that neurokinin receptor. When you block the neurokinin receptor, you abolish hot flashes. They had a very clever animal model that they used this in, and then this was rapidly translated to humans, and it seems to work quite nicely. So this is one of the few things that appear to be on a par with estrogen in terms of effectiveness. So this is going to be just a huge boost to my patients who cannot take estrogen and whom it's contraindicated. So it's very encouraging. I really hope these medications get to market, and that when they're in widespread use, they have the same efficacy they've had in these trials, and they remain as safe as they look in the clinical trials.
Excellent. Before we move on to a new topic, when of your patients that you sort of have this periodic stop, or wean, do the symptoms when they come back, are they the same as before? Are they worse? Is there any data on that, or are you?
Yeah, for some women, their symptoms are gone. So, it's almost like you can ride out the storm with the hormones, and then the worst time, the turbulence is over. So I've had some patients stop and they said, absolutely no symptoms came back. I can't believe it. And they're fine. And we're done. They don't need any more hormones. And then others will just say, they're back with a vengeance. They're just as bad as they ever were, not stopping now. It's usually pretty clear.
Okay. But not worse. You haven't
Yeah, no, they don't get worse.
Okay. All right. Well, there's some good news in the whole. All right. So the next group of questions are about mood and menopause. And the next Let's Talk Menopause webinar is actually on this very topic. So anxiety during menopause. It just says, can you discuss this issue? Will hormone therapy or a different therapy help with depression, anxiety, or mood changes related to perimenopause?
Yeah, we've looked a lot at depression and much less so at anxiety, but anxiety seems to be the cousin of depression and they seem to go together. So there is pretty good evidence that during the transition, treating with estrogen may improve the depression and anxiety. So if it's a mild case, I might try hormones first, but most often this may require a co-management with both an anti-anxiety or SSRI type medication and with hormones. But hormones seem to have a role in menopause. After menopause, they are not effective. So there's been a number of clinical trials that have looked at that. And it does seem to be somewhat helpful for anxiety as well. We do know that both anxiety and depression can become much, much worse. There's a small group of women that really get very severely affected and they need attention. That group also tends to be a group of women that are enriched in what we call adverse childhood experiences. And many women don't make that linkage, but it's actually a pretty hot area of research right now that women that have had multiple adverse childhood experiences, abuse, neglect, does not have to be physical. It can be verbal and just life events, even things like acrimonious divorces that as you experience as a child, this comes back to haunt women during menopause.
Gotcha. Next question, is there any vaginal cream that does not have parabens, which has been found in breast tumors? Why would a vaginal cream be better than a patch? Vaginal is so inconvenient and messy.
Yeah, most of my patients really despise the vaginal creams. So the pill, there's a pill, an insert, and a ring that can be used vaginally that are much, much neater. And in general, if I could make the creams go away, I would, except that some women that have had surgical procedures done that can't tolerate even inserting the ring or the tablets need those creams. So they have a place, but not really, if I was in charge of formularies, which I'm not, I would probably limit those and keep the other things higher on the preferred list.
Okay, I have another question here. Does hormone therapy really help with forgetfulness?
Yeah, mostly no. I mean, a lot of the forgetfulness, and I'll often tell my patients, if your spouse is in the kitchen also wondering why they got there, what they meant to get there, that's age related. That's got nothing to do with menopause. So don't look to hormones to make that better. If it's something more, then it might be improved. Some of the word recall specifically, that's the thing that seems to be the Achilles heel for women at that time of life. That might get better during the transition with menopause.
Gotcha.
With hormones.
Somebody jumped on late. Sorry if you've mentioned this already, but how is initial hormone therapy administered? A patch or pills?
Most of the recommendations now favor not using oral medications for the estrogen component, at least, because if you give estrogen by mouth, it can increase what we call it goes to the liver, it increases liver clotting factors, and it can increase the risk of blood clots. And there's about a doubling of the risk of blood clots in women. Blood clots are a fairly rare event, but they can be life-threatening. So it seems to be safer to give it non-orally. So that can be a patch, it can be a vaginal ring, it can be a gel that you rub into the skin, if those work for women. There is also some evidence that oral estradiol, as opposed to other forms of estrogen, may not have that increased clotting risk. But that's, again, observational, not randomized trial data. So in general, I will start with non-orals, and usually we use patches. That's the simplest thing for most women. But, I myself was a volunteer for one of the research studies that I did, and I was a disaster with patches. So I totally sympathize with patients who hate them. I got rashes, I had rings, lint rings all over the place. So it doesn't work for everybody. And for some women, they just don't stick. And then you need to go to one of the alternatives.
So last couple of questions here, where time is running out. Does the estrogen 2.5 patch daily thin the skin? Does it make it more soft? I feel like I get cuts more easily. And on my forehead, or is this just natural aging?
Yeah, probably that's aging. There's no evidence it thins the skin. There's some very limited evidence that estrogen may make a difference in terms of skin wrinkling, but I have reviewed that literature a great deal, and there's something that's called publication bias, where if your study shows a benefit of estrogen on skin, much more likely that it's going to get published and much more likely that it's going to get publicized. So those are the things that appear in the news when it's favorable. If it's either great or terrible, we live in an extreme age. So if it looks fantastic, it's going to be in the news. If it looks awful, it's going to be in the news. Everything in between, and the stuff that's just negative doesn't really get published, or it gets published in an obscure research journal. So most of the data on that is underwhelming.
Okay, and our final question, can you talk about the dosing you start patients on, and does that depend on the extent of their symptoms?
Often, yes. The old dictum used to be the lowest possible dose for the shortest possible time, but going back to the first patient that we talked about, who comes in and she's really just fed up. It took her a while to get the appointment. She had to cancel a couple of times because of her schedule. She's nuts. We're going to start at a higher dose. I will often ask my patient, do you want your symptoms to go away quickly? Because we could start high and then back down to titrate and just dose adjust, or we can start at the low or at the medium dose. And the medium dose for an estrogen patch is a 50 microgram patch. That's equivalent to about 1 milligram of oral estradiol. So there's all dose equivalents across the line for these things. And we'll figure out, that middle dose is often where I'll start, and then we see if that works and go up or down.
Gotcha. I'm just going to ask one final question here. In what percentage of your patients does this work? I mean, I've heard stories that sometimes hormones don't work for some patients. What, in your kind of all the years, all the patients, what would you how would you?
Well, I would say 90% of the time they work.
They work. Okay.
And about 20% of the time there's side effects. They cause annoying bleeding. A woman has fibroids and she starts bleeding and can't take them. They have some other side effect that's so aversive that my patient, even though her hot flashes are better, she doesn't like it. Some people get PMDD type symptoms from being on hormones and they don't like it for that reason. So then we'll go to something else. But in terms of symptom control, I have high confidence it's going to work. But yes, there are some people who paradoxically have ridiculous hot flashes no matter how high we push that estrogen dose. And currently we've got no explanation for that.
Okay, I think time's up. Thank you so much. I could sit and ask questions all day, but I think that's all that we have time for.
All right.
Thank you. I just want to say, before we sign off, I want to just do two things. One is I want to thank our Nina, and I want to thank Dr. Santoro. This was incredibly fascinating and illuminating, and to be able to have someone with the depth and range of knowledge that you have, Dr. Santoro, it's really a privilege for us to be able to learn from you, and we hope we can continue to do that as we grow as an organization, and we're sure you're going to be continuing to be involved in research, as we know you will be, Nina. We are going to do a brief poll right now that we hope everyone will stay and answer, because we really want to get your feedback. It is an anonymous poll. We really want to get your feedback so we can continue to be responsive to you in the content that we offer for you. We want to thank our partners. We want to thank Revel for partnering with us, Alloy for sponsoring us. And finally, we want to remind you all to sign up for our next Menopause Talk, which is going to be on June 28th, noon, June 28th. And some of you already asked questions about mood and menopause and perimenopause. And we are going to have an incredible panel of experts who treat women in perimenopause and menopause with depression, anxiety, irritability, and more. So we look forward to seeing you there. And everyone, if you can, please complete the poll. And thank you again to Dr. Santoro and Nina, and to our audience.